Hey guys, we're going to talk a little bit about PCA pumps. It's important to note why we would use PCA pumps and when they're appropriate and when they're not appropriate. They kind of come in waves. Generally speaking, if we've got one patient on the unit on a PCA pump, we probably have another patient on the unit with a PCA pump. PCA stands for patient-controlled analgesia. We use this to administer narcotics for pain management. It can be used for patients in end-of-life care as well. So sometimes if we're doing a continuous infusion of maybe fentanyl or something like that, we might do a continuous infusion through there. But beyond that, we would use it maybe in a post-operative patient that requires frequent pain medication. There are a couple of different options on PCA pumps. You can do continuous infusion only, which is what we would use in the circumstance of an end-of-life or hospice type patient, so that they're continuously getting the narcotic without having to do any work or hit the button to get it. There's a PCA dose plus continuous, which means that they are getting a constant basal rate of the medication, and then they would hit their button to get an extra bolus dose as well. Or there's PCA dose only, which means that they just have it attached and they can hit the button and get little boluses throughout the time frame. So those are the different options. So it's really important that you have two nurse verification on this for safety measures. You want to make sure that patients that have a PCA pump have all of their safety measures in place. You do want to Narcan available in the orders as well in the event that you needed it. Generally speaking, reasons to not use the PCA would be patients that in post-op cases really need to ambulate pretty frequently. It's often a frustration to have to do hourly pain medication for patients, but one of the things that our surgeons like is that it requires the nurse to come in and assess the patient that often. If you're going to go and give IV morphine every hour, you're having to lay your eyeballs on the patient and make a nursing judgment over whether or not it's appropriate to administer that narcotic. So you're seeing them and making sure that it's safe to administer the narcotic, which is one reason that maybe they wouldn't use a PCA pump. PCAs are great and they're wonderful, but it's really important that we have good nursing practice associated with it. So what does that look like? What is good nursing practice for a PCA pump? It would mean that we want to make sure that our patients are out of the bed and sitting up in the chair as much as possible. If they can ambulate, let's do that. It gets really hard to do that because with the PCAs, sometimes they get kind of tied down with a lot of different extra lines and tubes. PCAs come in an order set or a power plan. And what that means is when they order the PCA pump, it comes with automatic additional orders that require the patient to be on O2 at 2 liters via nasal cannula. That's regardless of their SpO2 reading. So even if their stats are sitting right at 100% on room air, because they have a PCA pump attached to them, we are automatically going to put them on O2 at 2 liters. It also requires CO2 monitoring, and that's something that we're going to talk about here. So they have a nasal cannula that's attached to a CO2 monitor. They automatically have to lug their IV pole around with them. In a lot of cases, it makes it harder for them to get out of bed anyway. And so some of these patients are still going to have a Foley catheter, which isn't necessarily appropriate, but sometimes that'll happen. And so they're less likely to get up and move around on their own. They are fall risks anyway. And so those are some things that we have to make sure we have good nursing interventions to kind of mitigate some of the side effects of the narcotics, which is post-op ileus, again, fall risk, maybe some pneumonia. We want to make sure that we're doing good IS and nursing practice. They've got their STDs on with the immobility and that kind of thing. You want to make sure that you have good frequent assessments, make sure that it's still appropriate for them to be on the PCA pump. So they also have to have continuous SpO2 monitoring. That's part of the power plan or the order set. So they're going to have a continuous pulse ox on them. So that's an additional line that they have. And then in the order set, they tell us hover to discover in Cerner, right? So you're going to hover over the nursing text order. And this is part of the nursing communication orders. So this isn't something that flows through for pharmacy on the medication order, whether it's morphine or Dilaudid or whatever the drug is. It'll be up in the nursing text for the power plan. And it basically says that the patients can't be on any other sedatives. That's our policy for the hospital. If they're on a PCA pump, They can't also have an additional sedative ordered for them because of the risk of respiratory depression. So that means that they can't have Benadryl, they can't have Phenergan, they can't have sleep agents at night. So it's very specific on all of those things, as well as, of course, the obvious ones like Ativan and Xanax and those types of things. But those Phenergans and the Benadryls and those types, the nurses have to really watch for and make sure that we don't also have those ordered for the patients, because you have an order in the nursing text and the communication orders that says that they can't be getting that. And again, that doesn't flow through for pharmacies, so they might have those medications verified, but it's the nurse's responsibility to make sure that they are not administering those sedatives on top of the PCA. They also can't be on oral pain medicine. So you're not going to have a patient that's on this in addition to Tylenol number 3, or on also with the oxycodone or something like that. So that's important to note. If there was an extreme case of poor pain management on a patient and the physician required that or ordered that they receive maybe oxy in addition to their PCA of morphine or whatever they're getting, it's very important for the nurse to do proper documentation. You would first want to let the physician know, hey, that's actually against our policy while they're on that PCA pump. And if the physician is insistent, then you would have to go in and make an additional, definitely document your communication, but make an extra order that says, okay, to administer oxycodone in addition to PCA and morphine or something like that. And then, of course, make sure that your leadership team knows that that's happening, because anything that steps outside of our policy, they need to be aware of to make sure that we're doing the right and safe thing for the patient. So you have to make sure that you have, obviously, a vital sign machine at the bedside, which we're fortunate to have in every room, because they're going to be on the continuous SpO2 monitor. You need your flow meter. You're going to grab this tubing here out of the medication room, and it's usually on that metal rack across from your Omnicell, and it has this O2 tubing that looks kind of crazy, and it has this little flap right here attached to it. So when the patients wear this in the nares, it's got this little flap that measures their respiratory rate and CO2 values, and it's got this kind of little Y off. And this hook will actually go into a separate chamber that goes on the outside of the PCA. It'll be a yellow chamber that you would connect this to, and that actually is their CO2 monitor. So it's going to measure their CO2 in addition to their respiratory rate to make sure we're in safe parameters. You have to get this purple key out of the Omnicell. It's usually attached to something kind of like this hairband that I have, so you can have it for safekeeping. And then make sure after you're done with it that you return it to the Omnicell, because again, somebody else on the unit might also have a PCA pump and they need access to that key to make any modifications. So on your Alaris pump, on your brain, the PCA has to connect right next to the brain. So you can't have this on the outside of another channel. The PCA chamber could not be over here. It has to be connected directly to the brain. And then your yellow CO2 chamber will be right next to that. So you're going to make sure that your key is in here. Where do you get your medication on a PCA? If you've got a PCA ordered, you are going to get your PCA drug out of your Omnicell in some circumstances. It kind of depends on your unit. Post-surgical gives a whole lot of narcotics. So they are going to have these loaded in most cases in their Omnicell if it's morphine or something like that. If it's dilaudid, oftentimes they're going to have to get it from pharmacy. And so either the pharmacy tech will bring it up, or in some instances, the nurse would have to go down to pharmacy and get it. If you're picking it up from pharmacy, it'll come with a yellow sheet of paper, which basically is a handoff sheet that says, hey, I am entrusting this nurse with the care of this 30 mL of Dilaudid. So you want to make sure that if you get one of those yellow papers, that you tuck it in and keep it with your drug, because that's where they're going to waste or report any waste at the end. If they discontinue the syringe before it's over, you're going to record any additional waste in there for that narcotic. So you are going to make sure that you've got your vital sign machine, you've got your O2, you've got your pump, your purple key, and of course your drug. And then you also need tubing, of course, to administer. You're going to get that from the CS room. It's a little bit different from our secondary tubing. You're going to attach it to the end of your syringe. You can manually prime these, or you can prime them from the pump. So it just depends on if you need to use very specific measurements. Maybe your patient is critical and you need to account for every last drop of that medication. Then you'll program or you'll prime your tubing with your pump. But you can also manually prime it. Just make sure that you're not wasting any as you go. Okay, so if I'm manually priming this, we're going to just kind of put that down there. Now, when this is the hardest part of the whole thing for new people putting in these PCA pumps. So you're going to scan this into the MAW and use your proper medication administration and follow all of your 6 rights. But your syringe, when it's ready, is going to go right here between this dark gray lip and this white plastic. There's a little bit of a little section right here, and this is where your syringe is going to fit right in between that. Then you're going to open this clamp and come in and lock it on top of your plunger. It's important to note on your syringe, if it's a 30 or 35 ml syringe, it's the difference in a monoject or termoject syringe. That's important to note because when we program the pump, it'll ask us for that, and that it tells the pump how much to push down on the plunger or how much medication to expect to be in the syringe so that it knows when it's time to alert us to get a new dip. And then we are going to, of course, I would have gloves on for that admin. And we are going to attach this to the port closest to the patient. I'm going to clean here. And attach my tubing. And make sure that your tubing remains clamped. You don't want to accidentally bolus Dilaudid or morphine to a patient. So make sure it remains clamped till you're ready to run your pump. We've got that going. I'm going to push this little clear chamber here. It's just kind of like a jacket that holds the syringe directly into the pump there. You have to have primary fluids infusing for your PCA to work effectively. They don't have to be infusing fast. They don't have to be getting a lot of fluid, but you have to have primary solution to administer the PCA, because when the PCA pump pushes down on that plunger, it's literally giving little tiny drops of the morphine or Dilaudid. And if you don't have fluid infusing, they are not going to have the medication enter that vasculature. It's not going to enter the circulatory system. And so essentially your patient won't be getting any pain medicine. So you need to make sure that you have fluids, even just infusing at 20 cc's an hour to help keep it flushed and continuous. So when they hit the button, it helps push that medication. So we are going to program our pump. It's also really important to note patient teaching with this. Patients that receive the narcotic sometimes are sleepy, and it's really, families are involved in most of these cases. And as with anyone, we want to make sure that our loved ones are taken care of, and we don't want them to fall asleep and wake up behind on their pain. We don't want them to be hurting. And so it's really tempting sometimes for family members to say, oh, jump again on this one. It's really tempting for sometimes family members to hit the button for patients and say, oh, I don't want them to get behind. So as a nurse, you need to do really good teaching and let patients and their families both know that only the patient can hit the button. And that is for safety purposes. And it's the best thing that I've found to do is just to be very transparent with patients when you're doing that, and let them know if they're asleep and you want them to get the pain medicine, wake them up. And if they can wake up enough to hit the button themselves, then they're able to have the pain medicine. And if they aren't, then you need to come and find me and I will come and take care of it, because one of two things would have happened. Either they're too sedated and you need to address that, or you can assess their need for additional pain medicine at that point. So I always tell families, you can actually cause them to stop breathing and have them go into respiratory arrest if you hit the button while they're sleeping. And so wake them up, and if they're not able to wake up, then come get me. That's the best thing to do so that they don't hit the button. I'm going to just program my primary fluids first, just to make sure that we've got those going in. Now, so I've got primary fluids infusing, and I'm getting ready to program my pump. This is where two nurses come in handy because you need to make sure that you have two nurse verification when you're programming your Alaris pump. So we're going to hit channel select here, and we're going to turn the key to the program position that's telling us to do that on the Alaris. It's having us verify the date and the time. So the time of day is 1:15. I'm going to hit confirm here. It's asking, is it a Monoject 35 ml syringe? I'm going to hit yes and confirm. Now it's asking for my drug. So I would have scanned this into the MAW. In this circumstance, we're using Dilaudid or hydromorphone. So I'm going to click that. It's asking me, I'm giving hydromorphone. Is it for acute pain or chronic pain? It's for acute pain. Now the concentration at the college on these pumps is programmed a little bit differently. This is not the normal standard concentration that you would expect to see at the hospital. So know that this is just for training purposes, but verify your concentration at the hospital with your orders and with the medication that you receive from pharmacy. So in this circumstance for training, it says it's a 0.2 milligrams in 1 ml. Is that correct? And I'm going to hit yes. And then it gives me a clinical advisory, which says to monitor the respiratory status and O2 saturation, which we do at MMH by doing continuous SpO2 monitoring and the CO2 monitoring. I'm going to confirm that. It says to attach the end-tidal CO2 module now, and that would be the yellow one that's required over here next to your PCA pump at the hospital. And then this is asking me to confirm my drug amount. So my drug amount in this training circumstance is 0.2 milligrams of hydromorphone in 1 ml, and I'm going to confirm that. And it's having me review the PCA pause limits. This is basically saying if I have a respiratory rate of 8, this is going to stop and freeze out my PCA so that the patient can't get a button. And so those are the pause limits on here. It's just safety that are built in. So I'm going to confirm it. Then it's asking for my infusion mode. So we talked about continuous or PCA dose or PCA plus continuous. In this circumstance, we're going to say that the patient, per our orders, is getting a PCA plus continuous. So the PCA dose is 0.2 milligrams with a lockout interval of every 10 minutes. That means that every 10 minutes, if the patient hits the button, they're going to get 0.2 milligrams of Dilaudid. The continuous dose is 0.2 milligrams per hour. At Midland Memorial, this will actually be a 4-hour limit for most of our orders. It kind of depends on how the physician orders it, but most of the time it'll be a 4-hour maximum there. And so then 4-hour max, this out here says 1-hour max, and it'll say the max limit is 1.4 milligrams every hour. So if in an hour I hit 1.4 milligrams based off of what's continuously infusing on my basal rate and what the patient gets from hitting the button, if I hit 1.4 milligrams, it's going to stop infusing everything until that hour is up, and then the nurse can reset it and it'll kick back in so it can start administering medicine again. So these are just additional safety features that are built in to prevent overdose. Then it's asking for a loading dose. It's only going to ask me this the very first time that I go to program the pump. A loading dose is basically an initial dose. So if my patient just got out of surgery, I want to go ahead and kick them off. I'm going to give them a boost, and then they're going to have their regular dose infusing. So you would check your orders to see if you have a loading dose. In this circumstance, per my orders, I don't have one. So I'm going to hit none. And then I'm going to hit confirm, and it says close and lock the door. So I'm going to come here, lock it, lock, and then take out your key. Don't leave your key in there. If you leave it in, the patients can turn it to program and take their own dose. We don't want that to happen. So then it's going to just have me verify. And this, again, is where your second RN is going to come into the bedside, check your orders, and confirm that you are giving 0.2 milligrams every 10 minutes with a continuous dose of 0.2 milligrams every hour with a maximum limit of 1.4 milligrams in an hour. And they're going to confirm that with Beacon and make sure that we are correct. And if that's correct, we're going to hit start. Then I'm going to come here, make sure that my line is unclamped. And it's going to scroll across this marquee saying that they're getting the PCA plus continuous dose of hydromorphone. Okay, the green light is on, so everything's good. If you'll notice on our dose cord, this is the button that you're going to teach the patients about. it will light up. It's got a bright green light in there. And so as long as that light is on, they can hit the button and it will administer the medication. So you're going to see after I hit that, it says delivering PCA dose. So you know right now they hit the button and they are getting the medication that they requested from hitting the button. If the patient hits it 2 or 3 more times, nothing's going to happen. It's only going to give them what they had programmed in there. So it's only going to give them what is programmed or allowed. So they can hit the button all they want, but it's just going to give them what's programmed into the pump. At the end, or every 4 hours, you need to document, assess their pain and document their pain, and then also assess your pump and make sure that what's programmed is still what's ordered and that there have been no changes and that everything's appropriate. You also need to go in and check your history every 4 hours and at shift change when you switch nurses. And so I'm going to show you guys how to do that. And there's a place in Beacon now for us to chart all of this, so it's really fabulous. But you are going to come over here and click on Channel Select and Options and Patient History. So I'm going to click on Patient History, and it's going to tell me what the history is for this PCA pump. So for my shift totals, the total drug administered is 0.203 milligrams. The total demand is 5. That's how many times they hit the button. The total delivered is 1. So if there's a discrepancy there, that might indicate that maybe your patient has poor pain management. They hit the button 5 times, but they were only able to get it once. So that's a good indicator that you need to reassess their pain, make sure it's managed, see if you need to call the doctor and make any dosing changes. You can also program bolus doses in here if the physician has ordered additional bolus doses. It's not common that they would do that, but it certainly is possible. We've done it before, but you want to be very careful. But you can bolus them from the PCA and account for that drug in here. You can also clear your history. So when we do that, you can go to clear history, and it will confirm that you want to do that. And you can still refer back to your 24-hour totals and see those. But that way it sets your next nurse up. So your night shift nurse or your day shift nurse that's following you, it kind of sets them up with a clear history screen so that they know what happened on their shift, but they can still refer back to their full 24-hour totals. So this is PCAs. The most important thing is to maintain safety and reassess your patient very frequently. Thank you all so much.